Good morning. I'm Dr. Shivakumar from the Pediatric Cardiology and Structural Heart Division of Madras Medical Mission, Chennai, India. And I have with me Dr. Tejasvi Ram, who is one of our postdoctoral fellows. And the other person who is going to assist me will be Dr. Pramod Sagar, who is a consultant. The other persons are Rabish and Jana, who are the scrub nurses, Surya and Prabhu in the radiology technicians, and Dr. Uday, who is taking care of the patient's anesthesia. We have a 34-year-old gentleman who is post-tetralogy, who has got left pulmonary artery stenosis and needs a pulmonary valve implantation. Dr. Pramod Sagar, my colleague, will introduce the patient to you.
Welcome back. Today we are again with an exciting case.
Go back to the
Our patient is a 34-year-old gentleman.
Go back to the
He is a case of tetralogy of Fallot with pulmonary atresia with a duct-dependent circulation. He underwent initial two-stage surgical repair from Great Ormond Street Hospital. Okay. The first surgery was a pericardial patch enlargement of the right ventricular outflow tract at 9 months, which was followed by complete surgical repair at 22 months, where the VSD was patch closed, the infundibulum was dissected, there was a transalveolar patch plasty of the RVOT, and the LPA, which was hypoplastic, was augmented using a bovine pericardial patch. He was doing well and he is having class 2 symptoms for last 3 years. His echocardiogram showed progressive right ventricular dilatation and pulmonary regurgitation. So we performed a cardiac MRI. There was significant elevation in right ventricular end-diastolic volumes, which was 199 ml. It's almost 22 ml increase in the last 1 year, and the RVEF was reduced to 46%, which was 50% 1 year ago. The right ventricle to left ventricular volume ratio was 2:1, and there was a pulmonary regurgitant fraction of 30%. There was severe LPA origin narrowing with the right to left perfusion of almost 6:1. This is the chest X-ray, which shows mild kyphoscoliosis. There is a cardiomegaly with a CTR of around 65%, and the RPA segment is dilated, whereas the MPA and LPA segments are not very prominent. This is an ECG which shows right bundle branch block with the QRS duration marginally prolonged than expected, and it is almost 130 to 140 milliseconds. This is the echocardiography. Here we can see that the right ventricle is quite significantly dilated compared to the left ventricle, and this is the RVOT. The images are not very good, so I will show the CT images in subsequent slides. This is the CT reconstructed image. This is a multiplanar imaging. Here we can see this is the RV, the dilated RV, the RVOT, which is almost pyramidal, and this is the LPA origin, which is quite significantly narrowed, and this is the hilar LPA. The RPA origin is fairly okay, and there is good sized RPA. The LPA hilum was measuring 16 into 15, whereas the origin was significantly narrowed to 3 into 6 millimeter. The pre-bifurcation MPA at this region was 18 into 20, and proximal to that there was one more area of narrowing in the MPA, which was 14 into 10 millimeter. The proximal RVOT was 24 into 20 millimeter. So this is the reconstructed image. Here we can see this is the dilated and trabeculated right ventricle. This is the right ventricular outflow tract, and I am slicing towards the LPA. This is in the lateral view or in the sagittal view. This is the RVOT. This is the LPA origin, which is narrowed, and this is the hilar LPA. Now I will show this is the RPA origin. Now I will slice again from cranial aspect. Now when I am slicing, you are seeing the aorta, then you will see the right ventricular outflow tract, the RPA origin, the RPA, and this is the narrowed LPA origin. When I slice further, we can see the LPA is roomy in the distal part. This is a segmentation. This is the RVOT with branch PS. This is the anterior calcification. I am turning it to make the LPA seen well. This is the LPA origin, the LPA hilum, and this is the RVOT. Here we can see the coronaries again. This is the right
20, 22, 24 radiation.
This is the RCA, and Sorry, I can't display. Can you open it?
So, Dr. Pramod, you are telling an interesting
Yeah.
clinical situation where the pulmonary regurgitation fraction in a post-tetralogy repair is close to 30%, which means it warrants some intervention. You also described about right to left perfusion ratio of around 6:1, which indicates significant left lung hypoperfusion due to a severe left pulmonary artery narrowing. And you also mentioned that the right ventricular end diastolic volumes are progressively increasing. Within the last 1 year, there is a 22% increase in the RV end diastolic volume. And the indexed end diastolic volume has crossed 170 ml per meter squared, thereby indicating that there is a need for a pulmonary valve. As well, we need to relieve the left pulmonary artery narrowing and bring about an equal perfusion to the right and the left lung. Yeah.
I will just show a virtual stenting here. So as sir explained, we are doing a stenting from RVOT towards the LPA. So this is the virtual stenting. Here we can see the LPA, the RPA origin will be flowing through the struts. So we will prefer to use a stent which has open cells here. Again, in the cranial slice, we can see here, this is the stent from RVOT to the LPA, and this will be the flow to the RPA through the struts. So we will be using a open cell design.
After
And
the
the thing
angio,
is,
I will ask you to show
in the
that still
proximal part
picture.
of the RVOT, we will do
Photo.
pulmonary valve implantation. And today we will be using an Indian Myval, which is primarily for a aortic valve, but we have a large experience on use in a pulmonary position. It's a nickel cobalt alloy with the bovine pericardium trileaflet valve. The distal part of the valve has open cells and the proximal has a PTE buffing. And this is available from 20 to 32 millimeters with 1.5 millimeter increments. And the navigator's delivery system is what we are going to use. The important fact is it is volume dependent expansion. Based on the volume, we can expand the balloon to the desired diameter, and all the valves can be advanced through this Python sheath which we will be using today. It will expand momentarily when the valve is advanced, so it is called Python, and we can use all the valves with this 14 French delivery cable. Thank you.
Thank you, Dr. Pramod. Actually, we have done a little bit of hemodynamics now. The right atrial mean pressure was 12 millimeters of mercury, indicating elevated RA pressures. The right ventricular systolic pressure was 60 millimeters of mercury. The right pulmonary artery pressure was 35 millimeters of mercury, indicating that there is a 25 gradient across the distal main pulmonary artery, which Dr. Pramod showed that it was narrowed. The left pulmonary artery was severely narrowed. The distal left pulmonary artery was showing a non-pulsatile trace of around 16 millimeters of mercury. So there was a very severe left pulmonary artery narrowing, and these are a couple of angiograms that we did. So the angiograms were done from the right and left femoral venous axis. The right femoral venous axis was having a pigtail. Can you run this angiogram? So the right femoral axis had a pigtail, a 6 French pigtail, through which we are now making this injection. We can appreciate that the right ventricular outflow tract is sort of pyramidal. There are calcifications in the region of VSD patch. There are also calcification in the region of proximal right ventricular outflow tract, which was originally reconstructed with a polytetrafluoroethylene membrane or Gore-Tex membrane. The RVOT is pyramidal. The distal RVOT or the distal pulmonary trunk seems narrow. The right pulmonary artery is quite roomy. The left pulmonary artery is severely narrowed. Can you freeze at the frame? So here we can appreciate that the left pulmonary artery is tightly narrowed at the origin, and then we have a distal left pulmonary artery which is sufficiently roomy. We heard that there was a bovine pericardial reconstruction of the left pulmonary artery twice during the first 2 surgeries. Also, the distal main pulmonary artery narrowing is contributing to the 25 millimeters of pressure gradient between the right pulmonary artery and the pulmonary trunk. We also did another projection in elevocranial to widen out the bifurcation. Here again we are seeing that the distal pulmonary trunk is narrowed minimally. The left pulmonary artery origin is extremely tight and the hilar left pulmonary artery was good in size. So the next step that we did was, next, can you show the measurements that we had? Yeah, so in the right pulmonary artery was measuring around 25 millimeter. The distal pulmonary trunk was 20. The proximal main pulmonary artery was around 27, quite roomy. Left pulmonary artery origin is very small at 4 millimeter, but the hilar part of left pulmonary artery was more than 17 to 18. In another projection, when we took a measurement, again we got a proximal pulmonary trunk measurement of more than 25, but the narrowed region of the distal pulmonary trunk was 17. Origin of the left pulmonary artery was 5 and the hilum was 17 and the right pulmonary artery was almost touching 20. So the strategy that was taken was to stent the left pulmonary artery towards the main pulmonary artery, thereby addressing both the left pulmonary artery stenosis as well as the main pulmonary artery stenosis with a single long stent, which is an open cell stent. I'll show the stent now. This is a stent that's called Zephyr. It's a cobalt chromium stent. It has got, can you get the dilator of the 14? It has got the distal two ends are closed cell and all the remaining part is open. I'm going to slightly enlarge the stent with the 14 French dilator. So this is a 14 French dilator with which I am slightly enlarging the stent. Then we are mounting it on a 20 millimeter Z-Med balloon. So the Z-Med balloon, 20 into 5 Z-Med balloon, which is compatible with a 12 French sheath. And we are now crimping it manually with the hands. We have parked a 14 French devil sheath across. Can you show the next picture? So we did a small pre-dilatation of the left pulmonary artery. This is a pre-dilatation that was done with a 10 millimeter Mustang balloon made by the Boston Scientific. The vessel fully yielded at 10 atmospheres and we went up to 12 atmospheres. So this is after the dilatation we made another check just to see what is the left pulmonary artery. Next picture. And here we find that it is still narrowed. Can you freeze the image? So indicating that there is a substantial recoil of the left pulmonary artery despite the balloon dilatation that we gave. So hopefully it should yield with a stent and the recoil of the pulmonary artery should be arrested by the stent. So now I am loading it onto a small 14 French loader. So this is going through a Lunderquist wire which has been parked in the left pulmonary artery. So this is a 49 millimeter long Zephyr stent mounted on a 20 into 5 Z-Med balloon and protected by a small 14 French sleeve, and it is going through a 14 French devil sheath, which is a long braided sheath that has already been parked in the left pulmonary artery. So here we are entering into the valve assembly of the devil sheath so that the stent is remaining protected. I have taken out the sleeve. I'm advancing the stent to the desired target. So the target was partially across the left pulmonary artery and partially across the main pulmonary artery. So I'm going to peel back the sheath in order to expose the stent. Protective sleeve will need to be cut off now because it's not giving me the space for pulling back. So this is the protective sleeve that is cut in order to create space. So I'm withdrawing the sheath almost around 70%. And at this point, I'm going to make an angiogram through the pigtail, 18 ml at 18 rate through this pigtail, in order to see how much I am protruding into the left pulmonary artery and how much I have come into the main pulmonary artery. Ready with the injection? So this is 18 ml at 18 rate. So we are positioned about 40% in the left pulmonary artery, about 60% in the main pulmonary artery. What do you think, Dr. Pramod?
Yes, sir. It looks nice actually. The position looks a bit fine. Maybe the position looks fine. I don't think we need to adjust any more.
Yeah. So I have completely unsheathed now, and I'm going to withdraw the stent, withdraw the pigtail, so that the pigtail does not interfere with the stent expansion. I'm coming a little proximal. At this point, let me make another injection just to reconfirm. 18 at 18. Freeze it. So the stent is now straddling the tight stenosis of the left pulmonary artery. Can you come and take over the inflation? Left pulmonary artery, and the distal main pulmonary artery stenosis is also. So at this point, I'm withdrawing the pigtail a little bit more inside. Yeah, we can go ahead. Just push the contrast. Yeah, keep on enlarging. Okay, go to, what is the burst pressure? 5. So go up to 5 atmospheres. 5. And deflate. You can see that the systemic pressure substantially drops now. Deflate. We'll wait for the systemic pressures to bounce back again. It's coming back. Let me try to advance the pigtail a little inside the outflow tract. Okay, let's give one angiogram here. Okay, now let's do some post dilatation in order to ensure that the stent is fully opened out. So we will start with, I have to take out now the, I have to take out the balloon now. Hold the balloon. While Dr. Tejasvi is holding the sheath, I have partially entered the sheath with the around the balloon so that the tip of my sheath is within the open stent. So get ready, 20 into 4 Atlas Gold. Prepare the 20 into 4 Atlas Gold balloon. You can take this out.
Deflator.
Fire out. So we'll flush the, pull the wire. So now we have to post dilate the stent to a larger diameter. I'm thinking about doing a 20 millimeter initially and then subsequently go up to 24. We may be considering a 24.5 millimeter Myval implantation mostly. We'll take the decision in another couple of minutes once we see how much the 20 into 4 balloon is getting expanded. So let me have a wet gauze.
Uh,
Yeah.
During this balloon preparation, can you explain to the audience what is the use of taking a long sheath deep into the LPA and then taking a stent rather than going without the long sheath?
Yeah, a very valid point, Pramod. The problem about taking the balloon directly will be, since the proximal part of the stent is now not fully opposed to the markedly dilated pyramidal right ventricular outflow tract, we may sometimes end up in the balloon crimping the proximal part of the balloon and deforming the stent. So in order to avoid it, we try to ensure that the balloon goes through the lumen of the stent and does not hit against the proximal flared part of the stent. So now we are taking in a 20 millimeter Atlas gold. So now I am exposing the, shall we go to, since 20 is quite a large size, I'll go a little cautious. We'll just go up to about 6 or 7 atmospheres. Go up, Dr. Pramod.
I'm going slowly. 1 atmosphere now.
Okay. I will give some initial inflation so that it is easy for you to take it further. Yeah, what is the pressure now?
It's 1.
Yeah,
I'm going to 2, 3,
okay.
4,
That's enough.
5,
That's enough.
4.
So now I am deflating. So fluorostore that and replay it again. Replay it. I am deflating the balloon, hoping that the pressure comes back. Actually, we are occluding the entire right ventricular outflow tract during each of our inflations, so the blood pressure drops down significantly. Now I'm going to slightly pull back the balloon so that we make a proximal dilatation as well. So at this place, can you go up?
Yes. I'm inflating to 2, 3,
That will be enough.
4.
Okay. Let's make an angiogram now. Each time when I give a inflation, the blood pressure significantly drops. There was a brief period of slow idioventricular rhythm now. Just come back, the pressure is picking up.
You can see it.
I'm going to again do the same thing. Advance the sheath a little inside. Hold it. The blood pressure has picked back to about 100 millimeters of mercury. So now, can we see an angiogram now? See how much the opposition of the proximal part of the stent is to the outflow tract. Can we make around 25 ml at 18 rate? Can we make the table a little up so that we see more of the right ventricular outflow tract table up? Yeah. Ready? Yeah, the proximal part of the stent is not opposed to the wall. So we will expand it so that the proximal portion is well opposed. Shall we do that with a reliant balloon? Yeah, reliant balloon is basically a compliant balloon that can be used. Can we make one more angiogram in RAO projection, the same previous projection? Can you show me the previous projection once again, that RAO? And while you go to the same projection now, yeah, that's RAO 34, cranial 46. So let us, so here, this was actually showing the distal main pulmonary artery trunk narrowing very clearly. Pramod, can you prepare this balloon?
Sure.
It needs a 50 ml syringe. Okay. So in this projection, let us try to expand the proximal portion of the stent and make it touch the wall of the right ventricular outflow tract. Can we make one angiogram in this projection? Sure. Yeah. Here it looks reasonably opposed. Show the previous view. The previous view was not showing a good opposition. Yeah, so probably on the leftward side of the outflow tract, we have not got a good opposition. So at this point, I will flush the sheath.
20 ml.
We'll check it. That's enough. I need only this.
Yes.
We don't need the indiflator. No, don't disconnect.
No, don't disconnect.
Disconnect it. Connect it. Okay. This can be disconnected. So the reliant balloon is a Medtronic balloon that is often used for the aortic aneurysm stent grafts. In order to flare the stent grafts to the wall of the aorta, it's a soft compliant balloon which will push the stent towards the walls of the outflow tract. So I'm taking in a reliant balloon. So I'm now peeling back the sheath and I'm going to give an expansion. This is a soft balloon and it expands quite substantially and flares the wall of the stent to the entire outflow tract. I'll do that a little bit more proximally also. So now we have deflated this balloon. I'll take out this balloon and put in the marker pigtail now. Can we get the marker pigtail? The blood pressure has come back to normal. The marker pigtail now will be positioned and we will get ready for 2 injections, 25 ml at 18 rate. We probably have to fill in some amount of contrast. We'll make one injection in RAO projection and then fill some more contrast. We can start preparing probably for a 24.5 millimeter Myval. 24.5. Okay, ready for 25 ml at 18 rate? So the right pulmonary artery is filling from the side struts. The main pulmonary artery now has got a stent that is well opposed to all the walls. Now we will go for another injection. Can you go to that LAO projection that we had, which is around 27 LAO and 40 cranial?
When we are repositioning, I think can measure the dimension once again.
Position the a little bit more up. So now we will Tejasvi, you can check one ACT and inform the intensivist about the ACT so that he can top up the heparin if the ACT is less than 200. Can we give another 25 at 18? Get a syringe for an ACT. Ready? So now we are shooting another picture in an orthogonal projection. Yeah, the stent is reasonably well opposed. Now what we'll do is change the devil sheath into a python sheath. Python sheath is the sheath for introducing the valve through the groin. It's an expandable sheath. As Dr. Pramod told, it's a 14 French. Can you come to AP view? It's a 14 French compatible sheath, but it can expand to accommodate a 22 to 24 millimeter valve. Can we? Okay. Now I'm going to take out the devil sheath. So this is the python sheath. Python sheath is a 14 French sheath and it has got an expansile sleeve. So along this sleeve, the sheath will open out to accommodate a 22 to 24 millimeter valve to go through. The proximal hub will be accommodating a 22 to 24 French valve, but the sheath that goes through the vein will be smaller. It's hydrophilic, activated by water. And now we are taking this python sheath, the groin. So it goes in rather smoothly. So now I am taking out the dilator.
So can you describe how will you choose the valve? Means the size of the valve.
Let's make some measurements. Prabhu, can you make a couple of measurements on both this LAO and RAO view? Pramod, we actually initially expanded the stent to a 20 millimeter Atlas Gold balloon. And then subsequently took up this Reliant balloon and expanded the proximal portion of the right ventricular outflow tract, which is actually a relatively healthy portion of the valve, a healthy portion of the main pulmonary trunk. So here, let us take the measurement. Probably that will give us a good idea about what is the valve size. By eyeballing I probably felt that it may be around 24, yeah, lower to lower, correct. So now we are doing the calibration. Yeah. Okay, a little below that. Little below. Another line little below. Yeah. So this is around 22 millimeters now. Can you measure the length of the outflow tract below the bifurcation? Below the bifurcation? Below that? Little below, little below. Yeah, from there to the end of the stent. Yeah. So it's around 24. I think a 24.5 millimeter Myval will have a undeployed length of around 21 to 22 millimeters. So that will be appropriate. So we have to land the valve on the proximal part of the stent. Can we measure again here in this LEO projection? Can we hold it here? I need a 20 ml syringe for flushing this python sheath. So as I speak, a 24.5 millimeter is being prepared. It's a nickel cobalt metallic alloy. It comes in two versions. The original valve of Myval was a hexagonal cells with a proximal skirt to prevent a paravalvar leak. The new design that has been made is called the octacore design, which is an octagonal cells. This octacore has got an advantage of reduced foreshortening. The regular Myval itself is it's a very low profile valve in the sense the length of the valve varies anywhere between 17 to 19 millimeter in its fully deployed state. The 24.5 millimeter valve will have an unexpanded length of close to 22 millimeter, and it probably might foreshorten to somewhere around 18 to 19 millimeter, giving a foreshortening of around 3 to 4 millimeters. The new octacore design does not have that amount of foreshortening. It's significantly less in foreshortening. And it has got struts for commissural alignment that is applicable to aortic valve, not so in the case of mitral valve, pulmonary valve. So this valve is being, it is a bovine pericardial leaflets on a nickel cobalt alloy. And the valve will be prepared by washing away the glutaraldehyde in 3 bowls of saline, each of around 30 seconds to 60 seconds. And at the end of about 3 minutes to 4 minutes, the valve is ready for crimping. They have got a special crimper called the valve de crimp. The crimper is used to get the valve profiled onto the balloon. Unlike the Edwards Sapien valve, it's not mounted on the shaft and then moved into the balloon. It is mounted on the balloon itself. The balloon is made in such a way that the distal end and proximal end will have a significant dilatation initially before the valve expands, so that the valve remains centered on the balloon with less chances of slipping proximally or distally. So now we are seeing the orientation of the valve. The valve is oriented in such a way that the proximal skirt is mounted proximally. I'll show the leaflets now, which is the last saline. So this is the tri-leaflet valve. You can appreciate that immediately it closes and then opens because of the stiffness of the bovine pericardium. But once you put it in the human pulmonary circulation, and when there is a good amount of pressure in the pulmonary artery, it will close. So now that is the navigator system. in the navigator system, this Myval is getting crimped, and this is the valve they crimp, through which the Myval is brought down in its profile. In the meantime, let me flush all the lines.
While they
Flushed.
prepare the valve, can we have some basic discussions about this procedure from beginning? Like the thing is, you use the ultrasound for ultrasound guidance for puncture. The importance of ultrasound guidance whenever we are taking a larger sheath like 14 or above is very important. Can you please explain the importance?
Yeah, whenever we are doing a venous puncture, sometimes we tend to make an anterior puncture and then go posterior wall and make a counter puncture. After we get into the lumen of the vein, we advance the guide wire and we get in the sheath. Subsequently, when we enlarge it to a 22 French sheath, the anterior wall of the vein with the venipuncture site is expanded to around 22 to 24 French. When the valve is stretched horizontally, the posterior wall, which was injured originally, will also stretch, thereby leading to a persistent leak of the blood from the posterior wall of the vein, and that will result in hematoma around the groin after we complete the procedure. So it's important to make a direct anterior puncture on the vein, especially when we are going to put in large bore sheets.
And
I do understand that there are a few questions that has come up in the screen. The first question is, what is the approximate cost of this particular valve? The valve with the navigator system and the assembly will be in Indian rupees somewhere close to about 15 lakhs, which can be around 15 lakhs will be around how much dollars will it be? Around $20,000, 20,000 US dollars. The second question that is asked is the venous valve also available in India? Yeah, it is getting registered now, and we are in the process of getting venous valve. At present in India, the valves that are available for use are the Melody from the Medtronic, Sapien from the Edwards, Myval from the Merrill, and Venus from the Venus Medtech. These are the 4 valves that are available with us. And so as I speak, the valve is getting crimped. You have mounted to 24.5 mm inflation, right?
And the choice of stiffer wire. Now in this case we have used the Lundaquist. So what is your opinion about the choice of wires in during the percutaneous pulmonary valve implantation?
It's very important to have a reasonably strong wire in order to manipulate our way through the right ventricular outflow tract. Nominal, yeah. So when I talk about a nominal inflation, that means loading a particular volume of contrast that will expand the balloon to 24.5 millimeter. Since it's a volume dependent inflation, if I want the 24.5 millimeter to go to 25 millimeter, half a millimeter more, I can inject 1 extra ml of contrast, and that will make it 25. And similarly, I can go up to around 3 ml or 4 ml to make it about 1.5 millimeter more. Beyond that, we don't need it because the next valve is available. This valve is available in multiple intermediate sizes as well of 1.5 millimeter. This is the profiled valve. So this profiled valve, now we are taking it through the Python sheath. So it has come out of the Python sheath. Now I am taking out the introducer. We hold this. Dr. Pramod will control the wire. So now I am going closer to the outflow tract. Now can we go to RAO? Show me the previous RAO projection. Yeah, correct. So in this RAO projection, let us see whether we are able to enter into the proximal portion of the outflow tract. Position the, yeah. So this, at this part, the advancing the balloon will need a pull and push. So I'm getting the wire deeper. I'm reducing the, yeah, hold the Python sheet continuously. I'm reducing the guide wire bias. I am making a loop in the right atrium in order to push the assembly. Okay. Now, can we go to LAO projection and see how much of change in LAO? Run this angiogram. Position. Okay, now I will try to loosen the loop in the right atrium, or I will get the ECG corrected. Reducing the loop. Let's make an angiogram at this point. Ready for angiogram? The distal end of the Myval is now overlying the origin of the right pulmonary artery. Can we go to RAO projection and make one another similar angiogram? The RAO seems to be less foreshortened compared to the LAO projection, and so probably that may be a desirable location to inflate the valve. Okay, so now let's make another angiogram here. The position looks okay to me. So now we are ready for the inflation. The initial inflation will be slow, and then as we go deeper, then it will be faster. Now start inflating, start inflating, keep inflating, keep inflating, keep inflating, keep inflating, keep inflating. Go full, fix the valve. Enough. Okay, deflate. Run this picture again. Let us wait for the blood pressure to pick up again. The blood pressure is slowly picking up. It's come to 100 systolic. So our intention to deploy this valve was in such a way that we are a little away from the pulmonary bifurcation. Let's make an angiogram at this point. Ready for the angiogram? So this is the right ventricular outflow tract angiogram. Now we need to carefully take out the navigator system. So I am reducing the tension on the navigator system to bring it to the middle of the valve. Fully deflated. So now we will make another angiogram of around 18 ml at 18 rate. The balloon has come out now at this point. The blood pressures are stable. Can we come to AP view so that I can take out the valve, take out the balloon through the python sheath? Show the balloon now. So the balloon is entering the python sheath. Show the valve again. So get the marker pigtail ready. Marker pigtail ready. So we have come out of the wire. Now at this point, I'm going to be aspirating and flushing the python sheath. I'm connecting this right ventricle to pressure now in order to see the right ventricular pressure. Previously, the right ventricular pressure was almost close to 60 millimeters of mercury. It was significantly elevated. I'm going to see it now. Show the RAO projection. I'm taking the marker pigtail.
Go to 100 scales.
Across the pulmonary outflow tract, and I'm going to connect the next pressure to the pulmonary artery. Don't lift. So show both the pressures in 40, 50 scales. Yeah. Take the mean out of the right ventricle. mean out of the right ventricle. The main pulmonary artery should have the mean, red color should have the mean, and yellow color should not have a mean. Yes. Increase the speed. There are a few ectopics. He's slightly venky backing.
He was having a trifascicular block before the procedure, and
Okay.
intermittently during the procedure he was having episodes of venky back.
Okay.
But it was not causing any hemodynamic significance as such. We are observing it.
Okay. So now let us get the valve and injection from the pulmonary artery. Ready for angiogram? So it's gone deeper into the left pulmonary artery. So we'll repeat an injection a little bit more proximally. Second injection here. Yeah. It shows that there is no pulmonary regurgitation. We will try to enter, we'll take out the pigtail from the left pulmonary artery. So we'll make the last angiogram through the right pulmonary artery now. We are ready. Yeah, it looks fine. Basically the flow through the pulmonary artery is through the struts of the valve. It's an open cell design valve. Give 18 ml at 15 rate. One last picture. I have brought down the catheter close to the valve. We are able to appreciate the valve. Can you show where the freeze it? Correct. Go back. Correct. So that is the valve. So the valve is functioning well. We also saw that the pulmonary artery was having a good diastolic hold. So I'm taking out the balloon out, and we are taking out the pigtail. Let's connect the systemic pressures once again. Figure of 8. The systemic pressures, can we see?
You can. The coronaries were far from the RVOT. That was not an issue as we analyzed from the CT.
I think it's maybe a good idea to
coronary check once.
Yeah, sure, we'll do that. Now, can we get a?
Can we have a LCA catheter?
So this is a Judkins right coronary catheter. Show the heart. Thanks for reminding me, Pramod. I was about to overlook the coronary, but as you said, the coronaries were very proximal.
was a dextro-rotated aortic route with more anterior and leftward origin of RCA.
Load little bit more contrast so that we can do a root angiogram. Okay, Judkins left. Was it a dilated aortic root, Pramod?
Yeah, it was mildly dilated aortic route.
So this is a normal Judkins left curve. Come to AP
It's a
projection.
4.
Contrast.
Yeah.
Can you come to caudal projection? Make the valve LAO. Make the valve become a circle. En face. Yeah, a little bit more caudal. That's good.
Yeah.
That's good. The coronaries are remote. I think the right coronary artery is far away. So let's complete the procedure now by taking a figure of 8 at the femoral venous puncture site. And so this figure of 8 is being taken with a number 2 silk, one stitch going below the sheath, and the second stitch going above the sheath. Can we cut it? I'll take just another reinforcing suture, because always 2 is better than 1. So these are 2 stitches now that has gone through. So we can appreciate that I am taking a knot of these 2 together.
Shall I remove this?
Yes, please.
I'm removing the sheath now.
Yeah.
Yeah.
We can probably put in a proglide also. However, figure of 8 is also another reasonably accepted method of getting a venous hemostasis.
So,
Okay. So shall we trim it off?
so what is the follow-up protocol of this patient, sir?
The follow-up now, what we'll do is, since there are large vascular access that has been taken, we would like to give low molecular weight heparin, enoxaparin, 60 milligram 2 times a day for the next 48 hours. Being a percutaneous pulmonary valve, we will continue the IV antibiotics for another 3 more doses. And then switch over the patient from today evening to aspirin plus Plavix in antiplatelet doses. So we will be giving aspirin at a dose of about 150 milligram and Plavix at a dose of around 75 milligram, clopidogrel at 75 milligram. So these are the the protocols. The patient will be called again at the end of 1 month to confirm that the vascular access sites are normal, the valve is functioning well, and then thereafter he will be on annual follow-up. As in any percutaneous pulmonary valve, it is very important to maintain all precautions against infective endocarditis. So strict infective endocarditis prophylaxis guidelines will be given to him. And we are pretty satisfied with the result.
And with respect to the rhythm, can we plan a holter and see what is the rhythm over time?
Possible. Actually, I feel that the patient is deeply sedated now. So there could be some element of vagotonia. So we will probably monitor this patient and identify what is his rhythm status and then take a call subsequent. The systemic blood pressures are good. The patient will be extubated by the intensivist in the next couple of hours.
And I don't think there is any other questions from the audience as such.
Yeah, so we will take this opportunity to thank for today's procedure, and we probably will get back again next Wednesday with yet another interesting intervention. Thank you. Goodbye from Madras Medical Mission Hospital.